Next one is neuroblastoma treatment options, individualized therapy. Thorsten Simon, Germany, please.
Yeah, good morning again. I was asked to give a presentation on individualized treatment of neuroblastoma, and I thank the organizers for the idea, because it was a really interesting topic to get into, and I hope you share this experience after my presentation. I want to go into 3 areas of possible treatment individualization. So this is once you can stratify patients by predictive markers, you can stratify or you can treat patients on individual molecular targets, and you can also individualize the treatment by response. And neuroblastoma is a good example for this, because the clinical course can be so different, and there are so many ways of high, low risk and responding poor or well, and so on. And it's well known to all of you that the age of diagnosis is a very good prognostic marker that presence of metastasis in all those patients, so it means stage 4 or stage M is a very important marker, and MYC-N amplification is probably the oldest molecular marker in clinical stratifying systems ever. And if we start, you all are probably familiar of the INRG activities, so coming from the MYC-N age and stage, after analyzing a very large database on 8,800 neuroblastoma patients, more factors were identified which are prognostic and at least allow individualization of treatment by better stratification of patients. And I don't want to go through all details, but you can see that still the stage according to INRG is in the system. So it's L1, the resectable localized tumors, L2, the unresectable localized, M, the metastatic MS, the infants until the age of 18 months, so this is the age. Histology plays a role in a subgroup of new tumors, of neuroblastomas. Also a grade of differentiation plays a role in the localized unresectable over 18 months old. MYC-N plays a role, at least for all. 11q aberrations play a role in the subgroup of patients, and also ploidy. So, and you can break down neuroblastoma into many, many different risk groups. So this is one approach. Looking into the low and intermediate risk patients, everybody knows that the prognosis is very good. There are a few patients who have relapses or progressions. Most of those progressions can be salvaged and the children don't die. And this is the survival curves of the German observation trial for localized infant neuroblastoma. I'm pretty sure that Barbara will show the same in pictures again. She will talk later on. And also for metastatic infant neuroblastoma, the prognosis is very well, so there's a very low event and death rate. And this is the point where individualization is necessary, so to identify those patients who need treatment or who need more intensive treatment. And the conventional way is to look at the response, and this is the German GPOH concept in low-risk neuroblastoma treatment. Actually, we want to observe all patients, so after operation, could be biopsy only, all gross resection. If the patient is well, has no symptoms, so no further treatment is scheduled. There's observation time, at least 1 year and at least until the 2nd birthday. And then if there is a residual tumor, it's supposed to be resected. And it turns out that most kids are very well and most parents are feel very comfortable with this policy, and the surgeons see no reason to operate on a child which is well. So many of those children don't undergo resection at this time. And if there is local signs of or a local situation which causes threatening tumor-associated symptoms, the children undergo at least one cycle of low-dose chemotherapy, and if the symptoms are under control, no further treatment. So this is individualized medicine. So if the symptoms are still there, so they are scheduled for at least 4 cycles of chemotherapy. And individualization is if there's still progression with symptoms, so the kids go on to the intermediate risk group treatment. And if there is progression to stage 4, of course, those kids undergo high-risk treatment. The results are not bad, and this indicates that this stratification seems to work pretty well. So this is all ages. There's a certain event rate in both arms, but observation group patients have events, but virtually no deaths. It's only very few kids who die. And if you look deeper into, you can see that the younger kids do better, what you would expect. So there's virtually no death in the group under 18 months. And it's also, in here, no deaths in the under 18 months and very few deaths in the observation group, in the older kids. And the intermediate risk patients do much worse, despite the fact that they get more treatment. The next approach will be that we look on predictive markers. This is what the SIOP does, the Gudrun Schleiermacher's data published. She looked at RACGH and was able to differentiate between those with numerical aberrations, structural aberrations, or no aberrations, and those kids are pretty good identified, and you can see a very good identification of the good risk group. In the GPOH, we follow the RNA expression approach, and these are data I showed last year here in Moscow. So Matthias Fischer and his group analyzed a data set of about 80 tumors, and these were really selected tumors. So they selected very good low-risk patients who survived without any chemotherapy, and they selected some high-risk patients who had a full amount of treatment and died despite intensive treatment, and they compared the RNA expression, and it's now about 709 patients in the database, so it's an international collaboration, it's all Japanese and American and European patients in there, and you can see by the cartoon that there is a clear cut between two populations of patients, and it turns out that this marker is better suited to differentiate the good and the bad ones, and you can see, so blue is the low risk, red is the intermediate risk group, or the unfavorable, excuse me, and you can see on the left side the event-free survival curves and the right side the overall survival curves, and the marker is best in the low risk group, so there's no deaths or virtually no deaths in the favorable group, and there are few deaths in the unfavorable group, but a lot of events which could be salvaged with treatment identification. The expression analysis is also very effective in the intermediate risk group, so those groups are a pretty good target for this strategy, but due to the concept of this classifier, it's not that good in the high-risk group, so this method is not suited for high-risk group stratification. And the future in Germany will be a new trial. The name has been made last year. We hope we can open next year. So we have the well-known risk factors. We don't skip everything at once, but we will include a PAM classifier in order to stratify patients and treat them according to their individual risk profile. In high-risk neuroblastoma, the situation is different. All patients undergo complex treatments with induction chemotherapy. This is the current German treatment with consolidation by stem cell transplantation. They undergo operations, MIBG treatment, radiotherapy, and sort of biotherapy. So we currently use the retinoic acid post-consolidation treatment, and the other groups do similar treatments. For example, the SIOP treatment, it's also induction, it's a randomized question, transplantation, and those kids undergo immunotherapy currently. The results are not very good, but in the very end, about half of those kids show a long-term survival, about 5 years. So this is the COG data, this is the GPOH data. So there is a group of patients in there who survive, and I recently analyzed the old NB 9070 trial, and it turns out the longer you wait, the better becomes the overall survival data. So there is a group of patients among the high-risk patients who survive longer, and the effort, the challenge is to identify front line. And again, we can stratify by response. This is an area of very controversial discussions. So this is the bone marrow cytology prior to stem cell transplant in the NB 97 2004 trial, and this is only kids stage 4 older than 18 months, all underwent myeloablative therapy and stem cell transplant, and one would expect that residual bone marrow involvement could indicate a poor prognosis. And the first message of those cartoons is there's very few patients with relevant residual bone marrow infiltration. There's only one patient left with infiltration between 1 and 10%. There's some patients with infiltration less than 1%, and there's the vast majority of patients has no residual bone marrow involvement by cytology and immunocytology, and there is at least no clear value on identifying to predict poor outcome. And the same is true looking at bone marrow PCR. I know that there are different data. Alexander in Yekaterinburg has made analysis. This is an ongoing project, cooperation with the Dutch colleagues, and those colleagues assessed bone marrow after 4 cycles of chemotherapy by PCR, and you can see that you can see nothing, so the curves are superimposable. Fast responders are clear after 4 cycles with negative PCR. No fast responders have signals after 4 cycles. So bone marrow assessments seems to be a very challenging area. It's easier to get some information on outcome on MIBG response. So there's the possibility of scoring MIBG scans, and this is what Boris de Carolis from Cologne analyzed, and he found out that it doesn't matter which score, you probably can't read it, but the one is SIOP score is down here, and this is the Curie scan, so it's different scoring systems, but anyway, you can clearly identify the good patients and the poor outcome patients. So MIBG response seems to be a method to individualize treatment by identification of poor responders in high-risk neuroblastoma. And the most challenging area is the targeted therapies, and we were facing another presentation this morning, and targeted treatment is not always individualized treatment, so there's many targeted treatments on targets commonly expressed in all neuroblastoma patients, so HDAC, cell cycles, angiogenesis, and GD2. And what I'm talking about in a few seconds is individualized treatment on targets expressed in subgroups of patients. And this is not that many targets. This is a genetic. You probably have seen this cartoon many times because it's so important. But you can see that the mutation frequency in neuroblastoma patients is quite low. There are a few genes which are mutated in a certain amount. There are very few germline mutations and many structural aberrations in the chromosomes. And finally, looking at targets who allow individualized treatments, I found only a few. So there's a MYC pathway. About 20% of patients have amplification, and there are some targets involved in this system of MYC, and there are a few trials going on some compounds. There's the largest field is ARC mutations. About 8% of patients have ARC mutations, and there are some compounds on the market. There are trials. Crizotinib is in brackets because it is not effective in one very common mutation. There was a trial on a CDK4/6 inhibitor, so this is an interesting target. This LAE trial is now closed, and I'm not aware on the results. It's not published yet, as far as I know. We had one patient who had a stable disease for a certain while, and there are other targets, and there are at least some trials on clinicaltrials.gov, and this telomerase inhibitor is already published in a phase 2 trial, but this field of individualized targeted treatments in high-risk neuroblastoma is still developing. One good example, I don't show the bad examples, but we have one kid with a germline ALK mutation, and she had brain metastasis, and after 4 months of treatment with therapinib, those metastases virtually disappeared, so some residual enhancement. So she's probably she responded very well. Then she underwent stem cell transplantation and then returned back to therapinib. And she is well. She was in the hospital last week for staging, but this is not a long-term outcome, of course. And I come to the end. So the summary, so individualized therapy, you all have heard, is a very emerging field. There's very much discussions, and in the way the knowledge about molecular diversity is growing. Also the efforts or the challenge of individualized treatment is growing. Neuroblastoma is a good candidate because it has such a large range of clinical causes. Individualized therapies require clear rules and standards, so individualized treatments are not everybody does what he wants. It's also best placed in prospective trials because the standard complex chemotherapy, the multimodality treatments are very effective, and the new treatments we have to demonstrate that the new treatments are better than what we did before. Thank you very much.
Thank you, Thorsten, for a very nice presentation. So one question acceptable. Do you have any question?
Everything unclear.
Okay, we discuss later. Thank you very much.